There is about 10% of the vision loss in the children worldwide is due to congenital cataract. This cataract could be bilateral cases and 50% due to mutation of gene that code for lens clarity protein. Could be idiopathic, which is about 30%, could be familial and hereditary. And we have a fair number of families with congenital cataract. For this reason, these families, they have little bit of education where they ask for assessment of their new babies. Could be an autosomal dominant or X-linked, which is rare autosomal recessive. Could be due to chromosomal trisomy like Down syndrome, 13 or 18, gene chromosomal abnormality, translocation, deletion, and duplication. Could be due to craniofacial syndrome like Hiller-Mann-Streiff or Streiff-Rubinstein type B syndrome, which is very rare. And you may not see these cases except 1 or 2 in your career. And you could see in this slide that we call sometimes the broad thumb syndrome or Streiff-Rubinstein type B syndrome. And you could see that the thumb in the right hand and the big toe in the feet is also as big. This is compatible with Rubinstein type B syndrome. If you look at the slide here, this is Hiller-Mann-Streiff, and usually they presented with some dysmorphic feature, big chin and the nose. And sometimes they have bilateral resolved remnant of the lens with just membranous changes. Subjecting this group, especially the Hiller-Mann-Streiff, to anesthesia is not a free risk. And I'm encounter one patient and one of our colleagues passed away while he's on the table. He was 9 months of age, and there was a difficulty to put the patient to the anesthesia. For this reason, when you have a patient with syndromic presentation and congenital cataract, subjecting such patient for GA is not free of complication. For this reason, you have to be sure that the patient is medically clear. Don't push patient for surgery if he has a lot of syndromic abnormalities and there is a risk of anesthesia, especially if you are working in a general hospital where there is no ICU and maybe there's no specialized pediatric in ICU patient. For this reason, subjecting patient with congenital cataract and chromosomal abnormalities or craniofacial syndrome should be very careful to subject this group of patients. There are certain diseases like Conrad-Hiller-Mann syndrome and Albright due to musculoskeletal disorders, and sometimes myotonic dystrophy. They may have developmental lens cataract changes. There are certain syndrome they may end with renal failure, and you have to be sure that you make the diagnosis in time, because sometimes you need a nephrologist to assist this patient, especially in Loeys syndrome and Albert syndrome, where you could see the posterior lentoconus lens changes. One of the preventable is the metabolic, which is a galactosemia, and you can see that this patient may present with brain damage, cataract, jaundice, enlarged liver, and damage in the kidney. If you caught this patient early, you may do diet restriction and galactose, and sometimes these patients do well, because if you didn't treat them, they will be subnormal mentally, and this affects them in education. If you caught them early, very early, and you may retain the lens's clarity and retain the systemic complication of the galactosemia. Fabry disease is due to deficiency of lysozymal, and you could see that there are some corneal changes like corneal versicolata. Wilson disease, you could see that this patient with some corneal changes, and diabetes mellitus also as known cause of lens changes, developmental lens changes. Sometimes this patient ended with retroretinal changes, the diabetic retinopathy and cataract, and sometimes you need to do cataract surgery to treat the retroretinal changes due to the diabetes mellitus. Intrauterine infection like rubella, cytomegalovirus, varicella, syphilis, iatrogenic like in a patient who received cortisone or exposed to radiation due to orbital tumor or intraocular tumors, like in patients with sarcoma, or in patients with sometimes retinoblastoma. Sometimes you need to treat them with radiation, where they ended with some lens changes due to radiation. Ocular abnormality, patients with anterior segment abnormality, they may end with cataract cells changes, like in an iridia patient, intersegment stenosis. Most of the cases with unilateral congenital cataract are idiopathic, and sometimes you didn't need to do any investigation for this group of patients. A patient with ocular abnormalities about 10% and microphthalmia or BFV, sometimes they have some lens changes. The lens changes is very variable, and sometimes just only small dot in the posterior capsule, and sometimes it is very aggressive vascularized lens abnormality and changes due to this congenital abnormalities. Trauma could cause unilateral cataract lens changes. Patient with retinal detachment sometimes may end with cataract lens changes. Retinoblastoma is very rare to cause cataract lens changes, but you may see such cases in advanced stage of retinoblastoma. What is the lab work, and do you need to do any lab work for patients with congenital cataract? Definitely, you have to have appropriate history and assessment, prenatal, postnatal, family history, all these needed to be documented in the file. And if you need to do a lab test, there is a list of tests that need to be done, like galactose metabolism by doing urine for reducing substances, galactose 1-phosphate, uridyl transferase, and galactokinase need to rule out galactosemia. Infection, you need to do the torch test to be sure that this patient is not exposed to during the prenatal to any viral infection, and varicella titer and PDRL. Metabolic diseases, sometimes you need to do urine for amino acid test to rule out Lewis syndrome, serum calcium to low if it's low in hypoparathyroidism, phosphorus high in patient with hypoparathyroidism, and glucose patient in diabetes mellitus, ferritin in patient with high in ferritin. Morphology of the lens changes is very variable. I mean, you depend on the type of the syndrome and depend on the cause, if it is autosomal, if it is recessive, if it is due to syndromic normality, could be spoke-like in Fabry's syndrome and mastocytosis. You could see corneal changes, and you could see find hepatosplenomegaly in this group of patients. Baculars, like in patient with diabetes mellitus, and increased blood glucose level. Multicolored flicks, sometimes these patients may present with minimal lens changes, where you could see flicks in the lens due to hypoparathyroidism or myotonic dystrophy, due to low serum calcium level or characterized facial feature and tonic grip. A green sunflower could be seen with Wilson disease and Kayser-Fleischer corneal rings due to the deposition of copper. A thin disciform could be seen in Lewis syndrome and where they have hypotonia and glaucoma. This is some slide of different type of presentation. You can see that it's a nuclear. This type of lenses sometimes, if it's not dense, maybe there's no indication to do the surgery. If the patient has no nystagmus, no strabismus, and he could manipulate, sometimes maybe there is no indication to do the surgery. We have two factors, the size of the opacity and the density of the opacity. If the size of the opacity is big, but the density is low, and you could see the posterior ball with good clarity, sometimes you don't need to do surgery. But sometimes if the density is, the lens changes its dense, you need to do some surgery. You could see this slide, this is you need to do some surgery, this is a nuclear change. Sometimes it is a lamellar lens changes, as we could see in this symbol form or in advanced form like this one. Anterior posterior lentoconus or lentoglobus or islet triplet could be seen in this slide and could be seen with galactosine, especially triplets, islet triplets. Posterior capsular ossification could be seen in some patients who receive cortisone or steroid or radiation treatment. Sometimes these patients, they have abnormality in the lens or the pupil. You could see this persistent pupil membrane and lens changes for the season. This type of cataract need to be done as early as possible, or could be sectorial like this one, where you don't need to do any surgery for this type, as long as you could refract the patient and you could see that the lens clarity is more than 90%, just localized lens opacity. In this slide, there is maybe no indication to do any form of surgery. Patient with BFV, like this form, it is very advanced, or this is, sometimes you could see that there's a stock between the posterior capsule and the optic nerve. Blue dot cataract, like in this patient, with time it may get worse and become more significant where you need to do surgery. Patient with a small spot like in mitten dots, sometimes you don't need to do any form of surgery as long as the clarity and the refraction is doable and accessible. Sometimes the lens change is not significant and there's still into clonus or into globus. If it's not affecting the vision and you could refract the patient, maybe you didn't need to do any form of surgery, but you need to consult the pediatrician and genetist to rule out any systemic finding. All patients who are just born need to be evaluated. And we think it is part of evaluating them. You may think that it should be part of the Ministry of Health program to assist. Now they are having a program to assist the cardiac abnormality and the hearing system. For this reason, we try to convince and advise the Ministry of Health to put it part of the assessment for healthy baby clinics to assess these kids to be sure that they are normal. You need to do a workup, lab workup when indicated, to assess the vision with these patients who are presented to you to be sure that the intraocular pressure is normal, there's no nystagmus, there's no strabismus, is there eccentric or eccentric fixation? Patient with eccentric fixation, that means there is have a dense abnormality, dense amblyopia, and maybe dense lens changes or maybe abnormality in the posterior pole. You have to do a slit lamp examination, assess the intraocular pressure because it's not uncommon to have a patient with congenital cataract and glaucoma. Assess the posterior pole. If the posterior pole is accessible by indirect ophthalmoscopy, that's okay. If not, you need to do B-scan, and you should not subject any patient for any form of surgery as long as the posterior pole is not documented as normal. Subjecting patient for glaucoma surgery or congenital cataract or anterior segment procedure without documenting the normality of the posterior pole should not be done. You have to do sometimes the EUA for this patient, check the IOP, corneal diameter. What is the importance of corneal diameter in this group of patients with congenital cataract? Those patients with microcornea, you need to do a peripheral iridotomy after cataract surgery. If you didn't do peripheral iridotomy, sometimes the posterior vitreous will detach and will block the pupil, and you will end up with more complication by pupillary block glaucoma. You need to know the normality of the scan and the axial length. Is this patient has any axial myopia or non-ophthalmic small axial length? You need to do a calculation for this group of patients with congenital cataract. The question when you need to do the surgery, as long as you identify the case and you are sure that this patient needs surgery based on your assessment, because the opacity is significant and the child is struggling with the vision, and maybe you need to know what is the time for surgery, and we'll go through that in a few seconds. Those patients who may present with congenital cataract but they are still in ICU, please don't do any surgery for patients still need a medical care. Once he's stable, you could do surgery, but no need to subject any child who is still premature or in the ICU where he is not yet medically clear. I'm encountered with some patients where they are taken from an ICU and operated by some visiting professors where they did cataract surgery and insertion of IOL for just a premature baby. Unfortunately, this child ended with blindness, legally blindness, corneal decompensation, secondary glaucoma. I think this is a crime, should not be repeated and should not be done. For this reason, doesn't mean that you are a skillful surgeon or qualified surgeon. You should push patient for surgery. You have to be sure that the timing is appropriate and you'll be sure that the surgery will be successful. Don't take our challenges or struggle with difficult cases. Who should do the surgery for patients with congenital cataract? It's preferable to be done and recommending pediatric ophthalmology, because these patients will need strong long-term follow-up and to assess the abnormality of any amblyopia, vision, glaucoma, exchange of the IOL if indicated. Anterior segment, they could do such surgery if the child is above 7 years, and this is our recommendation. If the patient has lens changes and normal vision before, but he has developmental cataract, anterior segment surgeon could do it, as long as they are consulting pediatric ophthalmology. For cases with unilateral cataract, it's okay to do the surgery between 4 to 6 weeks. For bilateral surgery, you have the horizon a little bit longer. As long as it's done within the first 2 months or 10 weeks, that will be okay. How you need to correct the aphakia after you did the congenital cataract. Aphakia correction, it's very safely could be managed with glasses, could be damaged contact lenses, or insertion of IOL for those patients who are above or who are appropriate age. The glasses are very safe, effective, and you could do secondary or sulcus IOL implantation at a later age without any difficulties. Contact lenses, we are struggle with contact lenses because the availability of a local provider or local agent sometimes is not available, and sometimes the family they cannot afford the contact lenses. If you have any failure with contact lenses, just go ahead with glasses. If the patient age is appropriate and you could put IOL insertion, that will be more preferable. This slide is not, doesn't work. Which type of IOL should we go with sulcus, 3 pieces, or we go with in the bag? It's preferable to be in the bag, but if it's a secondary IOL, it will be okay to put it in the sulcus as long as it's 3 pieces. You should avoid to put 1 piece in the sulcus because it will erode the iris and will cause erosion and dislocation very easily. For this reason, as long as you put the IOL in the sulcus, it will be very safe. Sometimes you may proceed with cataract surgery and unsuccessful capsulorhexis. You will find yourself you cannot put the IOL in the bag. Then in this case, you have to use the 3 pieces where there is the haptic could be inserted in the sulcus very safely. If the capsulorhexis is successful and posterior capsulotomy is successful, it's okay to put 1 piece in the bag without any difficulties. But please don't put 1 piece IOL in the sulcus because it will erode the iris with time. Avoid anterior chamber. It's not appropriate at all because it will result in the corneal decompensation and secondary glaucoma. No iris fixed IOL in young children. Some of our colleagues motivated and they did artisan for some patient where the IOL ended with this dislocation from the iris tissue and they start floating in the AC, causing corneal decompensation. Should you go multifocal, monofocal, toric, all these options is available as long as you work the patient in the proper way and discuss the situation with the family. If there is a need for toric lenses with due to have high stigmatism, that will be okay. Monofocal will work very well. Multifocal could be done for older children if the macula and vision prognosis is excellent, but it will not be good for patients with macular changes or poor vision. In unilateral cases, it will be okay to do the surgery as long as the child is 6 months or above this age. Bilateral surgery, we didn't recommend IOL insertion if children is less than 1 year, but it will depend on the family situation. Those family with low social economy and may they not afford the glasses or they cannot afford the contact lenses, it will be okay to put IOL insertion as long as the globe is normal, there's no microphthalmia, there's no abnormality in the posterior ball, and you are skillful in the surgery. You could put IOL insertion for children between 6 months and 1 year bilaterally. But for unilateral, sometimes we go up to 3 months and we put IOL in this group, but this should not be done except with if you have enough experience. Capsulorhexis is an essential IOL power. You have to, after the ultrasound technician provide you with IOL calculation, you have to have some clinical sense and surgical sense. What is the appropriate IOL power needed to be inserted, regardless if it is multifocal, monofocal, or toric, to work this with a lot of skills because the age of the patient is a big factor. Patient with unilateral cataract or traumatic cataract due to trauma, you have to know what is the refraction in the other eye. Patient, let's say that is hyperopic, +6 in the remaining non-traumatized eye or has no cataract, you have to know that this is patient. If you put an ametropic lenses, this patient will get it ended with anisometropia. For this reason, you have to put a power balance to the other eye to be sure that there is no anisometropia. You need to know the corneal chain, corneal keratometry of the cornea. You need to do the axial length. You need to know the age of the patient, and to be sure that IOL selection is correct. Anterior vitrectomy is recommended for all patients who are less than 6 years. And if you find that there is a posterior capsular opacification, even if the child is more than 6 years, it's preferable to do posterior capsulotomy and anterior vitrectomy. If the posterior capsule is clear and the child is more than 6 years, it's preferable not to do posterior capsulotomy as long as the child could sit for direct laser capsulorrhexis. Medication, it's preferable to use some form of antibiotics, steroid and phenylephrine as a post-op. One of the recommendations is to sometimes to do intracameral injection of some antibiotic to reduce the chances for endophthalmitis. It's preferable sometimes not to use any intracameral because it may sometimes end with some toxicity on the nerve and the retina. If the patient has intact posterior capsule, it's okay to give intracameral antibiotics like sulfoxime. But if their patient is post-vitrectomy, I don't recommend any prophylactic antibiotic to be injected into the intracameral or the vitreous because it may reach the optic nerve and cause some retinal or optic nerve damage. IOL power, you need to know the age of the patient, the history, the corneal diameter, the axial length, the neutrality, indication for aphakia correction. For this reason, based on that, you could select which type of IOL. For patients less than 6 months, usually the range of IOL is between 6 to 10. From 6 to 12 months, it's range between 4 to 6. 1 to year 3, between 1 and 3, it's about 4. Need to be still under corrected. This patient need to be under corrected. By this way, it will help him to be sure that he will reach the ametropia when he is older. A patient with, let's say, calculation IOL power is 28 diopter and he is 9 months of age. If you put it 28, you will end it with myopic changes. And you need to explant the IOL and change the IOL. For this reason, if the patient is 9 months and the IOL calculation is 28, I will go with the 22 diopter or 21 diopter to undercorrect him to be sure that this will compensate the axial changes. You could see that the complication that could happen after IOL, insertion and cataract, here the posterior capsular opacification, we need to do sometimes posterior capsulotomy by laser, subluxated lenses, and sometimes this patient may end with endophthalmitis, and this is a rare complication, but you have to be very careful that not to subject the child for surgery if there is a nasolacrimal duct obstruction or conjunctivitis or upper respiratory tract infection. Don't subject the case as emergency for congenital cataract. Congenital cataract is an urgent procedure, but not emergency. A patient presented to you and they are with congenital cataract. If he's in good health, no infection, no nasolacrimal duct obstruction, no conjunctivitis, no blepharitis, you could put him for surgery within a few days. There is no emergency. It's not an emergency to be done over the weekend or as emergency. For this reason, you have to work up and plan the timing in proper way. Follow-up is very essential to be sure that the patient get the appropriate refraction and IOP monitoring and treat the amblyopia if there's any form of amblyopia. And the glasses will work for protection and for distance and near. I mean, if the patient has become pseudophakic and you found him that after 1 or 2 visits that he still needs some refraction because you undercorrect him, this means that you need, if let's say that as we go back to the same patient who was about 9 months and IOL calculation was 28, but we implanted him with 21 or 26. This means that this child is undercorrected. We have to compensate him with the glasses and add some power for the near. By this way, he will grow up and he could assist the glasses power and adjust it accordingly and according to the axial changes and refractive changes. We are done with congenital cataract. We'll move to the leukocoria. Leukocoria as a wide subject. And what I need from the audience attendee to be sure that there is these two entities, the congenital cataract and leukocoria. One of them could be a vision threatening situation like in congenital cataract. And the second one could be life threatening like in case of retinoblastoma. Leuko mean white, pupil, coria is a pupil. This is a child with, you could see that white pupil due to retinoblastoma. When I say leukocoria, I mean, when a patient presented to you with leukocoria or masquerading presentation, the first point is to be sure that this patient not retinoblastoma and not congenital cataract. If patient is not retinoblastoma due to the normal posterior, due to the finding of the posterior pole normality after the B scan, then this could be congenital cataract, where you could refer him to the pediatric ophthalmology for possible assessment and surgery. You need to know what is the family history in patient when they present to you with white pupil, to be sure about prenatal, postnatal history of a trauma, parent examination. Sometimes you need to examine the parents to be sure that they didn't have abnormality. Sometimes the parents have one eye is removed, or they are treated for congenital cataract, or they have some form of abnormality for decision. Sometimes you need to examine the patient family to be sure that they didn't have history significant to this child. Outpatient examination is essential. You could examine the patient with portable slit lamp if he is too young, either under PABUs or under sedation or under GA as indicated. Subjecting kids to GA or AUA should not be the norm. You could have the ability to assist these children in the clinic and be sure that if the patient needs to go for GA based on your assessment, that will be planned at another stage. Vision assessment is very essential to be sure what is the finding in this patient who presented with leukocoria. Is he no light perception? Does he has any form of vision? And if the vision is nil, that means you have to work hard to be sure what is the reason for this leukocoria. You have to assess the intraocular pressure to be sure that this patient is not a case of congenital cataract, congenital glaucoma, or secondary glaucoma due to ocular pathology in the intraocular space. Check the child for nystagmus and strabismus, slit lamp examination, and fundus examination. It should be part of the normal workup of any patient who presented with a leukocoria. B-scan is an easy, simple technique that could be done even by us as a ophthalmologist, by the resident. We keep recommending availability of B-scan in the ER, and we found that it is more effective to have it in the ER where the resident could work and the B-scan and be more familiar. Sometimes the machine is available in some hospital. In the ER, sometimes not available, but I recommend that B-scan to be available in any ophthalmic emergency department. Color Doppler imaging is also help in certain cases. CT scan, we don't recommend CT scan for patients with a leukocoria because we didn't like to expose these children for radiation according to the American Radiation Society recommendation, except if there is a strong indication. For this reason, it's preferable to go with MRI. Fine needle aspiration should not be considered as part of the leukocoria diagnosis because we didn't know if there's any malignant process inside in the intraocular space, and preferable to keep it only for expert people who know how to do it and know how to assist these patients. Most diagnoses or differential diagnosis of patients with leukocoria, first you have to put in your mind retinoblastoma, pseudo-retinblastoma, or congenital cataract. The retinoblastoma and congenital cataract are the most important things you know, and you have to put it in your mind. When patient presented to you with leukocoria, regardless if it is just simple, straightforward congenital cataract, it's okay to identify the diagnosis, but you have to be sure that this case is not retinoblastoma when they presented with masquerading presentation. Classification could be, this patient could be a BFV, which we used to call it persistent hypoplastic primary vitreous, or could you to do embryonic ocular vasculature, retinal changes, anomalies, lipid, transudation, toxic retinopathy, retinal dysplasia, inflammatory condition due to trauma. Sometimes we have one patient a few weeks ago presented with masquerading presentation where we didn't know exactly there is retinal detachment with dense vitreous hemorrhage with subretinal hemorrhage, and patient has no light perception after assessment, and we decided to enucleate the patient because we need to be sure that this patient is not a retinoblastoma, and it turned out to be a trauma where we could identify that there is a laceration within the posterior sclera, and family they didn't know that this child received trauma, and luckily this child is not a retinoblastoma cases. You have to think about neoplastic and proliferative lesions. Pseudo-Retinblastoma could be seen mostly in the PHPV and retinopathy prematurity, posterior cataract, coloboma. It's not uncommon that the resident called us sometimes from AR to assist patient, or they think that this patient has a retinal mass, and when we go there, it is just a coloboma. Patient with uveitis, patient may present with uveitis and could be missed as pseudo-retinblastoma. Larval granulomatosis could be seen in some cases, but majority of leukocoria is presented are PHPV. Congenital retinal folds, Coats disease, vitreous hemorrhage, retinal dysplasia, and etc. Pseudo-retinblastoma could be seen in unilateral cases like in trauma, and in patient presented with unilateral leukocoria could be due to trauma, dense vitreous hemorrhage, BFV or Coats disease, medullobethelioma, or due to inflammatory due to larva. In bilateral cases could be seen in retinopathy prematurity. Could it be retinopathy prematurity and retinoblastoma? It's a rare coincidence. During the last years, only we encountered one patient who was referred to us as retinopathy prematurity treated elsewhere in Riyadh, and they found that there is a retinal mass need further assessment. Patient presented to us, and we identified that there is bilateral retinoblastoma, where this child who was a premature ended with bilateral enucleation and confirmed to have retinoblastoma. Sometimes these patients have the trisomy 13 or von Hippel-Lindau-angiomatosis, Nori disease, incontinent pigmentia, or accidental retinoschisis may present with bilateral pseudo-retinoblastoma and posterior ball abnormality or posterior ball pathology. How could we assess a patient to rule out if it's PHPV or retinoblastoma? Usually PHP have negative family history, while retinoblastoma sometimes it's positive or negative. 90% of patients with abnormality in PHPV are unilateral, while in retinoblastoma there's a 40% of bilaterality. Patient could have microphthalmia, cataract, microphakia, elongated processes, and area retrolental masses, and sometimes very rare to see calcium in cases with PHPV. While in retinoblastoma, cataract is very rare. Calcification is in the range of 95% with BYB scan or CT scan or MRI. This is a two slide. The slide in the right side is retinoblastoma, where there's a vision is already affected, but the life is also threatened. For this reason, unfortunately, this child ended with bilateral lesion. This is the child we showed at the beginning, which is rhizomelic chondrodysplasia punctata. The child passed away in the age of 2 years. I recommended the family not to subject the child for any surgery till we have obtained appropriate pediatrician evaluation. The pediatrician saw the patient and they decided not to recommend the surgery for the family. And this is the case, but family were told us that a few months later that the child passed away. Retinoblastoma is could present in very wide range. For this reason, could present with leukocoria, like in this child, and you could see that there is some secondary glaucoma. Could they present with esotropia? It's rare to see patients with cataract and synechiae and patients with retinoblastoma, but sometimes when there's a massive infarction of the tumor in the intraocular space, they may end up with this finding. You can see the B scan. Patients who present late, they have pseudo hypobian and seeds in the AC, and you can see preauricular lymph node. Unfortunately, this child passed away because he late presentation. You could find that there is calcification, and this is the cross section of the globe. This is the histopathology report of retinoblastoma, and you could see this rosettes, pseudo-rosettes. And of those residents who rotated with Dr. Azza, she could show them all these findings in the histopathology of nucleated retinoblastoma cases. This is a child presented with bilateral physical eyes, where we identify calcification in both eyes by CT scan and optic nerve invasion, and she ended with bilateral nucleation. This child now, she's about 28, and she has 4 kids. She gets married, she has 4 kids, 2 of them were affected with retinoblastoma, treated at KKH. 2 of them, luckily, they were normal. A patient with persistent anaplastic primary vitreous, as we said, it is very wide range. Sometimes there is a extensive vascular fibrovascular tissue in the posterior capsule and stalk. So like in this case, you could see the ciliary process, microcornea, and this form of patient sometimes, this type of patient, they didn't do very well. Most of the time they ended with aphakia, secondary glaucoma, and amblyopia. You could see the B-scan, the stalk, posterior bone. This is a cause of Coats disease, who is presented to us, which is the telangiectatic blood vessels. You see the B-scan, the CT scan doesn't show any calcium, and you can see in this slide the crystal of the cholesterol. Patient may presented with different chorio-retinal finding, like in this case, it's a trauma, this is toxocara, and this is larva. A patient with medullary epithelioma, like this patient who presented with ciliary body mass, and or could presented with abnormality in the posterior pole, where there is morning glory syndrome. Sometimes they presented with choroidal chorio-retinal colobome. B-scan is very essential. In this slide, you can see that is normal B-scan. This is a retinoblastoma. This is just a vitreous hemorrhage, and this is BHPV case. For this reason, availability of the B-scan and accessibility for assessment of patients who present with a leukocoria is very essential. You should not make the diagnosis based just on your clinical finding, except if you have enough exam and able to assess the posterior body to find easily, and you have good experience. But we are still seeing a lot of malpractice by even senior colleague because they didn't think about retinoblastoma in presentation. Patients sometimes ended with retinal surgery, intravitreal injection as endophthalmitis, vitreous stab, patient treated as a cause of congenital cataract, he treated as a glaucoma. For this reason, you have to be very careful not to subject your patient for surgery if you are not sure what is the diagnosis. This patient, you can see the A scan, there's high reflectivity, this represents a retinal detachment. This is just the vitreous hemorrhage with dense vitreous opacity due to vitreous hemorrhage and posterior vitreous detachment. This is a case of retinopathy prematurity. You can see a funnel shape of the retina. We used to do a color Doppler imaging, and you can see that there is this slide. You can see that the color Doppler imaging, and you can see that the perfusion of the blood in these cases. So we didn't find that this form of modality or this form of assessment is helpful. Just will tell us about the blood perfusion in this patient. This is a slide with the patient. You could see that there is no perfusion, and we identified that there is a central artery occlusion in patient with retinoblastoma. This is the case aim. You could see no perfusion, and you could see that there is tumor filling the posterior pole. This is the last slide. I'm done, and I think we have only 2 minutes. If you have any question, I'm willing to answer. We are almost done. I couldn't see any question in the chatting, and we are done. Thank you very much. We'll see you again, inshallah.